So welcome back. Are you able to hear me?
Yes, doctor.
Okay. Let me start sharing the next PowerPoint. Meanwhile, the remaining student will also join. So here is our lecture number 6. And just now we were discussing the very important concept, that is partial pressure. Partial pressure of any gas is due to dissolved form. Okay. Partial pressure of oxygen is due to oxygen dissolved in plasma. Partial pressure of carbon dioxide is due to
CO2 dissolved in plasma.
carbon dioxide dissolved in plasma. Any gas, if it is dissolved in plasma, it will create pressure. So the molecules have to be free in the plasma. Then only they can cause pressure, and that is called as partial pressure of that gas. Okay.
Doctor,
Yes, please.
can you review the important things in the RSP, please?
Can you finish these lectures, please?
Okay.
We'll after that we'll start with that also. Okay, so let's go fast now because the major two lectures that were very important more we have finished. Let us go ahead very fast now. Okay.
Mhm.
Quickly I'll ask questions now. Partial pressure of oxygen in alveolar blood. Oh, sorry, alveoli, not alveolar blood. Alveoli.
100.
100. Partial pressure of oxygen in arterial blood.
100.
100.
Partial pressure of oxygen in venous blood.
40.
40.
40.
Only 40. Okay. Remember that. 40, 40. Okay. Okay. What is the shape of oxygen hemoglobin dissociation curve?
Sigmoid.
Sigmoid
shape.
shape. S shape. Yani, now we don't say simply S shape, we say sigmoid shape. Please remember that. Sigmoid shape. Okay.
Mhm.
I'll just close the door. Some sound is coming from downstairs. Okay. Just give me 1 second. Okay. So the shape of curve is sigmoid curve. Okay. HBO dissociation curve. How much is the HB saturation in venous blood?
75.
75%. Okay.
Mhm.
Okay, very important. What are the factors which shift the curve to right side? Easy?
Increase O2 or CO2.
Increase. Carbon dioxide, ion, temperature, 2, 3 dPg. What are the factors which shift the curve to left side?
Decrease.
Decrease. That was our first question. Either increase or decrease. Now, second question is shifting of the curve to the right side, yani what? Means what? Please answer.
Easier to let go of oxygen to tissues.
Easier to release
Unload.
oxygen to the tissue, give oxygen to the tissue. Easier for the hemoglobin to give oxygen or let go of oxygen. Okay. Similarly, it is easier for the tissue to take oxygen. Okay. Easier for tissues to take oxygen or extract oxygen. Remember this one sentence. The meaning of curve shifting to right is easier for the tissues to gain oxygen, obtain oxygen, whatever words we use. Okay. That was very important. What is the normal oxygen carrying capacity of blood?
20 ml per 100 milliliters of blood.
20 milli per 100 milli of blood. Very good. Okay. Under normal condition, how much blood is oxygen is delivered to the tissue by 100 ml of blood?
5.
5 milli. The dark sentence here. Sorry, this one. Under normal condition, about 5 milli of oxygen is delivered to the tissue by 100 ml of blood. 100 ml of blood is carrying 20 milli, but or fakat 5 milli given to the tissue. Okay. So oxygen delivery to the tissue is 5 milli per 100 ml of blood, and carrying capacity is 20 milli per 100 ml of blood. Any difficulty till this part?
No.
No,
Okay.
clear.
We have finished oxygen. Let's go to carbon dioxide. Carbon dioxide, what are the three major methods of transport?
Bicarbonate,
Carbonate.
Okay.
Dissolve.
Dissolved, bicarbonate, and bound to.
Carbamino.
Okay, carbamino compound you can remember, or you can simply remember bound
Okay.
to hemoglobin or other proteins in the blood. Okay.
Mhm.
So these are the three methods of transport. Which is the major method?
Bicarbonate.
bicarbonate,
Bicarbonate. Okay. In which method chloride shift occurs? In which
Bicarb.
method
During the
of carbon
cyclo-
dioxide
bicarb
transport
transport.
chloride shift occurs? Sorry, please.
Bicarbonate form.
Bicarbonate form. Or carbon dioxide transport as bicarbonate has got chloride shift. In which method reverse chloride shift occurs?
And lung. At the level of the lung.
Okay, at the level of lung in CO2 transport as bicarbonate form. Very good. You want to remember Haldane effect? Okay, this is all about this lecture. Any question? No question?
No.
No.
Let's go ahead. So in this lecture, let me share again. Share screen, principle of gas exchange. So this is the next lecture, that is principles of gas exchange. So mostly we talked about partial pressure and diffusion. Okay. So in this lecture also, these are the two major concepts, partial pressure and diffusion. So the first thing is what is respiratory membrane? Quickly, please.
It consists of the alveolar epithelium, basal membrane, capillary endothelium.
Okay. And what is that? Why we call it as respiratory membrane and not
Because
simply
the gas
alveoli?
exchange occurs at this place.
Exactly. So the wall of alveoli, the interconnected tissue, and the wall of blood vessel together form respiratory membrane, and through which oxygen or carbon dioxide will travel. Okay. So it is a membrane through which gas exchange occurs. Layers of alveoli and capillary wall across which exchange of gases occurs between blood and lung is called as respiratory membrane. Can you remember this?
Yeah.
Yeah.
All of you, respiratory membrane is the combined layer of alveoli and capillary wall through which exchange of gases occurs between lung and blood. Can you remember? Okay. So we have repeated this sufficiently, right? What are the factors which affect diffusion? Quickly, please.
Surface area,
Surface area.
Okay.
Diffusion
thickness
constant.
of membrane,
Okay,
Then
and concentration gradient. Okay, concentration gradient includes what? What is concentration gradient? Okay, what is diffusion constant? Sorry, I wanted to ask diffusion constant.
solubility of
What
the
is diffusion
gas.
constant? Solubility of the gas and
Size.
Wait.
Molecular
weight of gas. Okay, so that gas molecule has got certain molecular weight and its solubility together, they are called as diffusion constant. Okay, next question is, what is the effect of increase in membrane thickness?
Decrease.
Diffusion. What is the effect of increased surface area? Increase diffusion. Very nice. Let us go ahead. What is the normal diffusing capacity of lung? Sorry,
21.
21 milli. Okay. In an average young adult male, the diffusing capacity for oxygen under resting condition is 21 milli per minute per concentration difference of 1 millimeters of mercury. Okay. During exercise, it increases 3 times. What is the major method of increase in diffusion during exercise?
Surface area increase.
Increase capillary surface area.
Okay, so the answer is during exercise, the diffusion increases by increasing the surface area through dilation of blood vessel. Very right. Can you remember this?
Yeah.
Okay. Okay. Any question from this lecture? No question?
No.
Clear, doctor.
Let's see the next lecture. So in this lecture, we discussed lung volumes and capacities. This lecture is very important for your lab also, okay? So we are going to discuss OSPI also. You can see my application. Which application you are seeing?
PowerPoint.
PowerPoint.
Okay. So why it mentioned separately? Okay. Let us go and see. As I said, in this lecture, we discussed major volumes and capacities. So can you tell me what is inspiratory reserve volume?
1,000.
No, not the number. We are not interested in number here, okay? If any number is important, I will tell you. So what is inspiratory reserve volume?
The air, the main.
Okay, the amount of air that can be inspired, extra air which can be taken in more than tidal volume, above tidal volume. That is inspiratory reserve volume. What is residual volume?
The air is remaining in their lung.
After?
Maximum.
Maximum break
After
expiration.
maximal expiration. The amount of air remaining in the lung after maximal expiration is called as residual volume. Amount of air remaining in the lung after normal expiration is called as capacity. You are right. Functional residual capacity. Okay. So remember, both the sentences are same. One word difference, therefore answer changes. So the first sentence is volume of air remaining in the lung after maximal expiration is called as
Residual.
volume.
volume of air remaining in the lung after normal expiration is called as
FRC.
functional residual capacity. Here it is mentioned, functional residual capacity. Can you remember this?
Yes.
Please remember that. Okay. Now this is the chart which you need to name. All the names you have to remember. Okay. This is not about theory. It is about OSPI. So as I said, OSPI will have two stations. One will have this chart, another will be a case history related with obstructive, and you have to identify whether it is obstructive or restrictive lung condition. But this chart will be one station. Okay, so very important for you to remember everything about this chart. Let me point out. Let's give this chart some time. It's not going. How do I project this? Okay, so here we are. Where is the pen? Is there a marker here? Pointer options, pen. Okay. What is this? Can you see my pen marking?
Yeah. Tidal
What is
volume.
this?
Tidal volume.
Tidal volume.
Tidal volume. From tidal volume above, what is this?
Inspiratory capacity.
Inspiratory reserve volume. Below tidal volume up to this black line is called as, quickly,
Expiratory reserve volume.
expiratory reserve volume. Okay. Below the lower level of tidal volume and above up till the peak, what is that?
Inspiratory capacity.
Inspiratory capacity. Okay. Below level of expiration here till the top, it is
Vital capacity.
vital capacity. Okay, very clear. What is this?
Expiratory reserve.
Volume. Very good. Below expiratory reserve volume, what is that?
Residual volume.
Residual volume. Together, what is this?
Functional residual
Functional
capacity.
residual capacity.
Functional residual capacity. This is how you have to identify. Okay, all these arrows will be there, names will not be there. Instead of a name, it will be written A. You have to identify what is A. Instead of this name, it will be written B. Can you identify this?
Yes.
Yeah.
So that was our first station for our OSPI. Okay.
Dr. Faisal and Osri, it will be MCQ.
This chart will be shown. You have to identify what is there. Option may not be there. Don't believe that it will be also MCQ. You have to write sentences. Okay.
Okay.
Okay. My favorite question. Define pulmonary ventilation.
Volume
Amount
of
of
air
air.
breathed in 1 minute.
Okay. Define alveolar ventilation.
Amount of air that participates in gas exchange in 1 minute. Oh. Yeah, reaches the alveoli.
Reaches the alveoli. Can you remember the difference between pulmonary ventilation and alveolar ventilation?
Yeah.
Yes, all of you. All the exams, this question was asked, okay, in different way. Pulmonary ventilation, alveolar ventilation, it will be asked again.
Mhm.
So remember what is alveolar ventilation and how it is calculated. How to calculate pulmonary ventilation?
Tidal volume times respiratory rate.
Tidal volume times respiratory rate. How to calculate? Very right. How to calculate alveolar ventilation?
Tidal volume minus
volume
dead
dot-
space times
Okay.
Respiratory rate.
Tidal volume minus dead space together multiplied by respiratory rate. Very good. So remember this, will not go into detail, just remember that, okay? One sentence, anatomical dead space is equal to physiological dead space. Is it normal or not?
normal.
Yes. This is how you calculate alveolar ventilation. This is the definition of alveolar ventilation. Please remember that. Okay. Do you have PowerPoint slides for lab?
Yeah.
Please, can you WhatsApp me for lab? Okay, so that we'll discuss that. This slide we'll discuss at that time. Okay, clear?
Yeah.
Okay, let's move ahead. We have less time. We'll discuss the second station of OSPI from those slides. So that is all from this lecture. Any question you have?
Yes, Doctor.
Please.
In spirogram graph, should we know the lung volume?
I cannot say no. All of you got my point?
Yes.
Yes.
Explain to her later. Okay. So the point is, the most important thing from spirogram is to identify. Okay. Theoretically, you are supposed to remember the major volumes. Not all, but major volumes. The major ones are tidal volume, inspiratory reserve volume, residual volume, and functional residual capacity. Okay, these are the major ones. Yes, thank you, Abdurrahman. I received that. I just saw the message. I'll open later. So this is all about this lecture. Any other question, please? Shall we go to next lecture?
Yes, Doctor.
Yes.
So, what's the next lecture? Okay, so the next two lectures were about mechanics of ventilation. Okay, so in this lecture we discussed mostly about compliance, right? The second part. Are you able to see? No? Sorry.
No.
So in this lecture we discussed mostly about the compliance part. So these were the major things which we discussed in this lecture. One was lung compliance, and second was airway resistance, and then surfactant. These are the three things which are very important in this lecture: lung compliance, surfactant, and airway resistance. Can you remember this? These were the three major concepts we discussed in this lecture. Okay, so define lung compliance. What is the definition of lung
Ability of the
compliance?
lung to expand.
Okay, it is the ability of the lung to expand. It is a measure of change in lung volume for any change in pressure. Okay, change in lung volume for change in pressure. Simple words which you can remember is changing lung volume for change in pressure. This way you can remember. Which is the major factor which determines lung compliance?
Elastic or surface.
Major factor. There are two factors. One is elastic, second is surface tension. So
Alveolar
of
surface
these two, which is the major one?
alveolar surface.
Alveolar
Surface
surface.
tension. Alveolar surface tension. And how is surface tension reduced?
Surfactant.
Surfactant. Surfactant, what is the function? What is the function of surfactant?
Increase surface area.
Increase compliance. Oh, okay.
Can you see?
Decrease surface tension.
It decreases the surface tension. It will not affect surface area. Okay? It will decrease surface tension. That is the function of surfactant. Let me go ahead and see any other thing. Okay. What are the conditions? Give one or two examples of condition related to surfactant deficiency. When there is absent or decreased surfactant.
Respiratory distress syndrome.
In
Newborn.
And in
Adults.
In adults. So one condition is in newborn and one is in adult. Okay. So both are called as respiratory distress syndrome, occur due to deficiency of surfactant. Any difficulty till this part? Okay. So the last important thing in this lecture is airway resistance. Can you remember that? What is airway resistance? What do you understand by
Radius
airway
of the
resistance?
conducting airway.
Sorry, please repeat.
Determines the radius of
Okay, what do
conducting
you mean by
airway.
airway resistance? What is the meaning of that resistance?
Resistance to airflow.
Okay, so opposition for the air to flow. Okay, preventing airflow or decreasing airflow. So can you tell me how you increase this resistance and it decrease airflow?
Membrane thickness
No.
or radius.
Membrane thickness will affect
COPD.
diffusion, not the movement of
Constriction.
air in the
Obstructive lung disease.
obstructive lung diseases. There is increased airway resistance. One example is
COPD.
asthma. Okay, you can take any example. There are 4 given here. Okay, so you can take any examples, but the most famous one will be asthma. Okay, second most famous one will be COPD. Okay, so remember about airway resistance. There will be decrease in the radius of conducting airway. Okay, can you remember?
Yes.
The size of the airway or bronchi will decrease. Yani decrease radius of the conducting airway occurs. Can you remember this?
Yeah.
Yes, all of you?
Yes, doctor.
Yes,
Can you, doctor,
Yes, please.
can you repeat what you just said, please?
Okay. I'm going to summarize airway resistance again. Airway resistance decreases airflow. Increase airway resistance decreases airflow. Airway resistance will increase when there is decrease in the radius of conducting airway. Yani bronchoconstriction. Okay. Decreased radius causes increased airway resistance. Bronchoconstriction causes increased airway resistance. Example of diseases where bronchoconstriction occurs or decreased airway resistance occurs is COPD and asthma. These are the sentences you have to remember. Okay. So the primary determinant of resistance to airflow is the radius of the conducting airway. Okay. You can discuss this point amongst yourself later. Let's go ahead. Any other question? No question?
clear, doctor.
Okay. Sorry. So this is the first lecture in mechanics, where basically we talked about the 3 major pressures and we also talked about some muscles. Okay, so this is a very straightforward lecture. Can you tell me what is pulmonary ventilation?
Amount of air that you breathe in 1 minute.
Amount of air going in and out in 1 minute. Okay. Can you remember the first sentence? Instead of me asking you a question straight away, it is an active process. Okay. Can you remember this?
Yes.
Inspiration is an active process. Okay. Then we go to the next concept which was discussed. That is expiration.
Passive process.
Expiration is a passive process. How many calories are used for expiration?
0.
0. What are the 3 major pressures in relation to respiration or breathing? 3 major pressures. Intraalveolar pressure,
and intrapleural.
intrapleural pressure, and transpulmonary pressure. Okay, clear? Okay, so remember that these are the 3 major pressure. For intraalveolar pressure, you have to remember the normal pressure. How much is the intraalveolar pressure?
760.
Okay, so can you remember this intraalveolar pressure? Okay, So this is all from this lecture. Any question?
No.
Okay. So now I'm going to share you the next slide, the last lecture. That is the number 1 lecture here. Here introduction was there. Mostly we discussed the anatomy, functional anatomy of respiratory system. Okay. So before that, we talked about external and internal respiration. And in that, one very important concept which you have to remember is respiratory quotient. Can you remember what is respiratory quotient? What is respiratory quotient?
Ratio of CO2 produced to oxygen consumed during
Is called as respiratory quotient. It is the ratio of CO2 produced to O2 consumed. So that is respiratory quotient. Next question is, what is the normal respiratory quotient on a mixed diet?
0.8.
0.8. Can you remember these 2 points for respiratory quotient?
Yes.
Yes.
Can you give me 2 examples of non-respiratory functions of respiratory system?
Acid-base balance.
Okay.
Secretion base.
These 2 functions are very important. Okay. Can you remember these 2 functions?
Yeah.
Secretion of ACE, which angiotensin converting enzyme, which converts angiotensin 1 to active form, that is angiotensin 2. Okay. Let's go ahead. So the rest of the slides are all anatomy. In anatomy, the most important concept was conducting zone and respiratory zone. What do you understand by conducting zone?
The first oxygen generation.
Okay,
It's only to develop the air.
it will only transport air from atmosphere towards the lung, towards the alveoli. It will not cause gas exchange. What is respiratory zone?
Where the gas exchange.
Gas exchange occurs.
In this part, a gas exchange occurs. Okay. Okay, there was one very important slide. Okay, here it is. Because it colors after loading. I did not see the slide. This slide is very, very important. Can you remember this slide?
Yes.
Bronchoconstriction will occur when there will be stimulation of which receptors?
Muscarinic.
Parasympathetic.
Parasympathetic, you can say, but in the option it will be muscarinic. Okay, I asked you about receptors. Okay.
Okay.
Okay. So muscarinic receptor stimulation results in bronchoconstriction. Which receptor stimulation will help in bronchodilation?
Beta.
Tattoo.
Which medicine will help in bronchodilation?
Ventolin.
So medicine which stimulates beta 2 receptor, you can say, or
Morphine.
medicine which are stimulating sympathetic nervous system, right?
Yes.
Okay. What will be the effect of histamine on bronchioles?
Constriction.
Bones constriction.
Constriction. Can you remember this?
Yes.
This is all from this lecture. Any question?
No.
No, clear, doctor. Thank you.
Okay. So this is all the theory lectures we have discussed. I received your PowerPoint slide from Abdul Rahman. Let me download it. I have downloaded it, opened it. Let's go to that slide now. Okay, where is the slide? Okay. Sure. Are you able to see the slides?
Yes, doctor.
Yes.
Are these PowerPoint?
This is PDF.
Oh yeah, why PDF? Why not PowerPoint? Okay, issue. No issues. We got all the information we want. Okay. What are you seeing on the screen now?
Flow volume.
It paused.
The PowerPoint or PDF? What you are seeing?
PDF.
Okay. So any question related to thanks. Somebody sent me another document. Any
It's
question
PowerPoint.
related to the first station, please?
No.
Clear, Doctor.
What you are seeing on your screen? What I am sharing?
Still the PDF.
PDF,
Still
not the
PDF.
PowerPoint?
No, Doctor.
No.
Okay, no problem. Are you clear with the first station?
Yes.
Yes, Doctor.
I said in OSPI there will be two stations. Do you have any question related to the first station? Yani spirogram.
No.
Very
No,
clear.
Doctor. Clear,
Let us
yes.
go to the second question. The second station, it will be a case history. Okay.
Mm-hmm.
So in this case history, some information will be given in a table form. Okay. About a patient. Okay. The
Doctor,
information will be FVC of that person, FEV1 of that person, and FEV1 FVC ratio of that person. Okay, it will be given, and also the predicted value will be given, and percentage of predicted will also be given. Okay.
Doctor, the screen
So
is
what
frozen.
Screen is
Frozen.
what happened?
On the Chrome.
Doctor, stop sharing and again.
Okay. Okay. So share screen and PDF. Where is PDF? This one is PDF. Are you able to see now?
Doctor,
Yes.
Yes,
now.
Doctor.
No, we can't see the PDF.
Yes, PDF I am sharing. Are you
Yeah,
able to?
Yeah.
Yes,
Okay.
Doctor.
Okay, so forget about the PDF now. What I said is very important. A case history will be given. Okay. A case history with data of patient will be given. Okay. And in that data, there will be three values which will be given: FVC, FEV1, and FEV1 FVC ratio. Okay. The number the patient got will be given. The predicted of that person will be given. Any difficulty till now, till whatever I have said?
No, nothing. No.
All clear.
Okay. So the data of actual person, patient, predicted of that patient, and percentage of the predicted will be given. If FEV1 is less than 80% of the predicted and FVC also less than 80% of the predicted, then that person will be restrictive, right?
Yes.
So you have to read the table and identify. If FVC is normal or less, maybe slight less, but FEV1 is lot less than normal, then it will be obstructive, right?
Obstructive. Yes, Doctor.
So point to remember for your exam is how do you identify obstructive disease and restrictive disease. In obstructive disease, FEV1 will be very less than normal, less than 50%, maybe less than 70%, always. Okay. FVC may be normal or maybe little decrease. Okay.
So you want just in the OSPI write the obstructive or restrictive, right?
There will be two questions in
this session.
yes, all session will have two questions. Okay. So one is this major one, obstructive or restrictive. Second is seeing the table, tell me whether FEV1 FVC ratio is more than 0.7 or less than 0.7. You